Good morning, Dr. Gurveer. Dr. Gurveer, can you hear me?
Good morning.
Good morning. Dr. Monica, can you hear me?
Yeah.
Dr. Hemant, sir, good morning.
Good morning. Is that Dr. Amita? आपका
Yeah,
नाम
yeah.
नहीं है.
Yes, sir. Am I
Morning.
audible clearly?
Yes, very clearly, very clearly.
Yeah.
Okay,
Good
sir.
morning,
Okay.
Dr.
Good
Dr.
morning.
Madan. Good morning.
ठीक है, दिख रहा है ना clearly?
हाँ जी, clearly.
Can I just share my screen and see if that also works?
Yes, sir. I'll just give you the right. Just give me a second,
हाँ
sir.
जी,
Just
हाँ
a
जी.
second. I'll have to close my screen, then I'll give you
हाँ,
the rights. Just
no
give me.
problem, no problem.
Good morning.
Good morning,
Good
Muktinder
morning, sir. Good morning, sir.
Dr. Monica, मेरी screen दिख रही है अभी?
नहीं.
अच्छा ठीक है. I'll just give the rights to Dr. Hemant, sir. डॉक्टर हेमंत आप प्लीज टेस्ट कर लीजिए, शेयर कर लीजिए.
एक मिनट, हाँ जी.
हाँ जी सर.
Okay, is my screen visible?
Yeah.
Yes sir.
Yes.
Absolutely sir.
चलो, बहुत अच्छा.
Can you just close that for 2 minutes sir?
Yeah, I'm closing.
Yeah.
I'll just go on to stop sharing.
Yes sir.
Okay. आज तो मौसम साफ हो गया.
हाँ जी आज अच्छा है सर.
कल भी अच्छा था.
Any day today after so long.
So long. This time it has been a nice winter.
Yes sir, absolutely.
Enjoyable winter. जो North Indians है ना उनके लिए ये ठीक था.
बिल्कुल परफेक्ट है. Just allow me a moment sir. Okay, so shall we start sir?
Yeah, please.
Good morning everyone. I, Dr. Amita, on behalf of International Homoeopathic Foundation, welcome you all once again after so many days. And today we have a special guest with us, special speaker with us, Dr. Hemant Madan sir, who is heading the cardiology department in Narayana SUPERSPECIALITY Hospital. So I welcome you all. आज वेदर बहुत ही अच्छा है and I think कि आप सब इस सेशन को भी बहुत एंजॉय करेंगे. So just to introduce IHF, IHF was founded in the
Make
year
it full
2016.
screen, Amita.
It
Full
is
screen.
not full screen, sir. I request everyone to put yourself on mute mode, please. Sir, is it full screen now?
No. You mute all first. You cannot expect people to be silent. Yeah.
Hemant sir, once I finish, I'll give you the unmute rights, sir. So the International Homeopathic Foundation was founded in the year 2016, which aims to promote homeopathy through academics and integrated approach. Since inception, we have been organizing various free health camps, seminars, homeopathic medical education series. The most talked about 3 days successful International Homeopathic Congress was organized by Taj Vivanta Dwarka at Taj Vivanta Dwarka 2016. We have also proposed a credit system for homeopathic doctors to Ayush department, which is in progress, and we feel that one day it will definitely be approved by the Ayush department. So we have been organizing virtual international homeopathic summits and mega panel discussions during COVID-19. So today our session is mainly on cardiac complications during COVID, diagnosis and management. And we welcome Dr. Hemant Madan, sir. I request Dr. Monica to unmute yourself and please introduce Dr. Hemant Madan, sir, to our audience.
Thank you, Dr. Amita. A very warm welcome and good morning to all. And I must say it's a great way to start this beautiful day with such relevant topic of today's times. And as Dr. Amita has already told, today's topic is cardiac complications during COVID, diagnosis and management. And we are fortunate to have with us Professor Dr. Hemant Madan from NARAYANA SUPERSPECIALITY Hospital, Gurgaon, to throw light on this topic and enlighten us. And I would request Dr. Madan to, apart from telling us about cardiac complications during COVID, also throw some light if there are any complications due to treatment of the COVID and vaccinations. And Professor Dr. Hemant Madan is an experienced and accomplished cardiologist with large and varied professional experience of over 18 years. He is MD from Pune University, DM Cardiology from Sri Chitra Tirunal Institute, Trivandrum. His field of expertise is complex coronary and adult interventions, pediatric interventions, peripheral interventions, advanced pacing and device management, pediatric and fetal echocardiography. He is recipient of Vishisht Seva Medal by President of India, Best Citizen Award, commendation by Chief of the Air Staff, commendation by Commander-in-Chief, Gold Medal in MD Medicine. At present, he is Director and Senior Consultant Cardiology and Pediatric Cardiology at NARAYANA SUPERSPECIALITY Hospital, Gurgaon. So with this short intro, I would request Dr. Madan to please take over.
Yes, sir.
I will need rights to share the screen.
Yes, sir. I'll just give you that. You can share your screen, sir.
Okay, is my screen visible to
Yes,
everybody?
sir. Yes, sir.
Thank you very much, organizers and Dr. Amita in particular for having got in touch with me and giving me the opportunity to talk on this wonderful January morning. It's really a pleasure and an honor to be among you today. And I think there's no more pressing, kind of medical urgency or emergency that we can deal with in today's era other than COVID. Everybody talks only of COVID. Everybody wants to know only of COVID. And therefore, it is pertinent that we talk about this condition today. Since I'm a cardiologist, I will restrict my talk to the cardiac problems that we have encountered in this COVID pandemic. I would request anybody and everybody to ask me questions as and when they come to their mind. They can put it in the chat box. They can ask me towards the end of the talk. It's of course a very freewheeling talk, and therefore we are not going to kind of be bound by any particular format in this talk. It as informal as it can be. We of course know that cardiac complications during COVID are extremely common, and there's a lot of confusion. There's a lot of dilemma about what's really happening in COVID and particularly related to the heart. Let me tell you by giving some statistics. It has now been proven that after the respiratory system, of course, we know that COVID is a respiratory virus. After the respiratory system, the second most commonly involved system in COVID and coronavirus infection is the cardiovascular system. It has led to various kind of complications and various kind of presentations. We still do not understand the whole situation. There have been huge studies, huge articles written on this, but we don't really understand what's happening. Even the mechanism of cardiac complications, mechanism of heart complications and vascular complications is not fully understood. We don't understand which phase of disease these complications come, whether they come early or they come late, or whether they are direct complications because of the virus or they are indirect complications because of the immune system activation, which happens because of the virus. So you can imagine, uh, how much in the dark we really are. Just to stop here for 1 minute and tell you about the level of ignorance. When we were students, there was a very kind of educated and a very well-read senior of ours. He was a senior resident when I was a junior resident. So once casually I had got placement in two different institutes for my DM cardiology, and I asked him that where I should head for my DM. So he says it doesn't matter where you head. What you do with your DM is what's important. And remember that as you go along in the field of medicine, more and more education leads to an understanding that you know less and less about health and about medical science. He says when you do MBBS, you feel you know everything. When you do MD, you realize you know nothing. And when you do DM, you realize even others know nothing. So it is more of an education of what we don't know and don't understand than what we really know. So coming back to my topic, uh, the treatment of these conditions is still evolving. We don't really know how to treat these conditions. There are some additional problems with COVID infection. One is that many heart patients do not come in time for treatment of their established heart conditions because of fear of COVID in the hospitals. So this is a peculiar problem that we are encountering, not so much in the third wave, but in the second wave, many patients actually had complications or died at home because of cardiac issues, because they were too scared to come to the hospital. There is another aspect related to this, which is how will interventions fare in these patients? Suppose a patient has a heart attack who needs a standard intervention. How will this intervention behave? Whether there is a fear of transmission of this disease. Suppose there's a COVID positive patient who comes with an acute myocardial infarction. My fear is, will he transmit it to me and my staff? Will he transmit COVID to me and my staff? And my other fear is, how will this intervention behave in a patient? Because we know that COVID is an inflammatory situation. We normally avoid interventions during inflammatory situations such as infection. So should we withhold intervention? Should we delay intervention? Should we not do intervention? These are conditions which we don't really understand. And I'm glad somebody talked about the effect of vaccination and the cardiac conditions. So I am going to very briefly talk about the role of vaccination and what the cardiac data is so far. So having just introduced the topic and having once again emphasizing that there is a lot of there are a lot of areas which we don't know, which only time will tell or only future studies will tell. I will just present 5 or 6 index case studies to see how COVID and the heart can present. My first case is And these are all real life cases. These are all, cases which I have encountered over the last, say, 1 year, 1.5 years, since the second wave. The first wave, actually, we did not really realize the cardiac complications. But the second wave onward, we've started paying more attention to the cardiac complications. So the first case is a young male who recovered from COVID 3 weeks ago, continues to complain of fatigue and, inability to do even basic tasks. Clinical examination, heart rate is, he's found to have very slow heart rate, found to have bradycardia, heart rate of 38 to 40, but he's not had a fainting episode. ECG shows sinus bradycardia, that is, it's a normal rhythm, but there is a slow heart rate. Echo shows normal left ventricular structure and function. That is, essentially, there is no structural abnormality of the heart, but the heart rate is very slow. Just I wanted to concentrate that this patient is a young male, about in his 30s. Now we have an elderly male, very similar, 68 years old, recovered from COVID. He's the other extreme. He complains of very fast heart rates with breathlessness. Heart rate is around 90 to 100 per minute. His saturations are normal, so obviously there is no lung infection. His echo is normal. We'll come to management of these. As I told you, the study, this talk is about diagnosis and management. So I'm going through with the presentations of cases. We'll talk about management a bit later. The third case, this happened in our hospital. Very sad, but at the same time very interesting from a doctor's perspective. Young male, he was admitted for COVID. On his way to recovery, sadly the only child of his parents. He was recovered. He was planned for discharge. This happened in wave 3. He suddenly collapsed on the morning of discharge, and he could not be revived. Sudden cardiac death in a patient who's otherwise recovering from COVID. This was very early on in wave 2. We really did not know, how to treat and what treatment to be given. Again, another live case, 58-year-old chartered accountant from Amritsar, fully recovered from COVID, COVID negative on 3 different occasions. Now complains of general fatigue and episodes of near fainting and fainting. ECG shows multiple ventricular ectopics, multiple, missed beats. Holter shows multiple runs of non-sustained ventricular tachycardia. They are all short runs, but multiple runs, up to around 40 or 50 runs in a day. And echo, you can see an otherwise healthy chartered accountant, not very old, now has severe ventricular dysfunction of both the right and the left ventricle. Left ventricle ejection fraction is only 25%. Right ventricle ejection fraction is about 30%. So, another clinical entity of biventricular failure of ventricular dysfunction. The fifth case, again a live case, which I did about, I think, 5 days or 6 days ago. I encountered about 5 or 6 days ago. A young male comes with anterior wall myocardial infarction. He's only about 33 years old, COVID positive. He has ongoing pain. I have, presented it as a problem, though we have done with the management. He has ongoing pain. Now, the first dilemma that I encounter is whether to thrombolize this patient by the conventional method or to do an angiography and then proceed. The second question is, when you do an angiography, whether to stent this patient or not to stent this patient, because as I told you, COVID is an inflammatory process. We are very wary as a cardiologist. I am very wary of whether we should do interventions on these patients with ongoing COVID or not. I'll come to the management a bit later. I think this is a last case, a young male who has recovered from COVID. He, after recovery, 2 weeks or 3 weeks later, he presents with sudden onset breathlessness and low blood pressure. Saturations are again found to be low 85%. Chest X-ray is clear. Echo shows a dilated right ventricle with right ventricular dysfunction. We obviously suspect pulmonary embolism, which is confirmed by CT pulmonary angiography. And when we do the angiography, CT pulmonary angiography, we find bilateral pulmonary embolism. So, I have finished with the case presentations. We can take a brief pause here and ask if there are any questions, and then we'll go on to the management of how we manage these cases and what is the current data. So, Dr. Amita, if there are any questions or anybody wants, we can take a 2-minute break and people can ask questions at this stage.
Sir, there are questions actually, and people are still entering. I think we should continue the session and take the questions at the end, if that is
Okay.
fine with you.
No, I'm fine.
Okay.
I'm fine because I will discuss the management. Of course, then we can involve everybody and ask for questions or criticism about management.
Okay, fine.
So I'll just run through these cases once again to tell you what the data is about these particular patients.
Fine, sir.
So the first case, as I told you, was COVID-related bradycardia. That is the essential syndrome that COVID causing slow heart rates. It was very well described in the second wave with the Delta variant that younger patients with COVID, the older patients presented with tachycardia, the younger patients presented with bradycardia. Now, as you all know, bradycardia, there is no real medicine which can increase heart rates other than, maybe aspirin and some nebulizations and all that. Otherwise, there is no real medicine which increases heart rates in a sustained manner. We have lots of drugs which can slow down the heart rate, but there is no real drug which increases heart rate. Now, here is a patient who's sitting on the edge. Of course, this particular patient settled down with just conservative management. And, I just told him that if you have fainting, come back. Otherwise, continue to exercise as much as you can because exercise can increase heart rate a little bit. Have more tea or coffee because tea, coffee are sympathetic, agents, and they can increase heart rates for some time. Otherwise, there is no real drug which can increase in heart rate. I just want to mention here that I also got his thyroid profile done, and his thyroid profile was normal. But you can imagine that suppose his heart rate was 30 and below, we would have actually needed to implant a pacemaker for him, in spite of the fact that he is he's a candidate who's likely to recover in some time. Slow heart rates documented can last for up to 6 months after COVID infection and are very commonly reported, particularly, as I said, in the younger patients. The second patient is just the opposite. Elderly male, recovered COVID and has fast heart rates. Now, as I told you, fast heart rates, we have many drugs to control fast heart rates. There are beta blockers like metoprolol or atenolol. There are calcium channel blockers like diltiazem. And of course, there is a new drug called ivabradine, which is extensively used now. So in this particular patient, I gave him metoprolol because beta blockers also, reduce chances of sudden cardiac death. So this is one patient in whom we needed to use beta blockers to slow down the heart rate. I think this patient still continues to be on beta blockers because his heart rate still remains in the high 70s, early 80s range. I also want to tell you that all these patients, we did D-dimers and inflammatory markers to see whether there was ongoing inflammation and to consider steroids in case there was ongoing inflammation. This is extremely, extremely sad. This was a reality in the COVID second wave. Sudden deaths, sudden unexpected deaths in young patients. Of course, this discussion can only be, we don't have the patient anymore. This discussion can only be on a post-mortem basis. Uh, the likely causes are either a massive myocardial infarction leading to sudden collapse, or a very large pulmonary embolism leading to sudden collapse. But extremely unfortunate, as I told you, these were days when we did not understand COVID fully well. We didn't understand that they needed blood thinners for long periods of time. And therefore, many of these patients were on very, haphazard kind of treatment when the wave started. But these are all problems which happened during the COVID wave. Now, this is a problem which we are still encountering. Patients who land up with ventricular dysfunction or LV dysfunction because of COVID infection. We don't know whether it is an inflammatory process or whether it is the primary COVID infection which is affecting the heart. There is a very large biopsy study from Italy where it's a lady pathologist who did autopsies and did the myocardial staining and myocardial studies, and she concluded that the heart looked exactly like it looks in viral myocarditis. That means there is direct involvement of the heart. So till that time, we continue to manage these patients as we manage ventricular dysfunction. That is, we give them medicines to reduce the load on the heart. We keep their blood pressure under check. And in this particular patient, because he was a patient who was a very kind of educated and a very aware patient, I also advised him an AICD to prevent sudden cardiac death because he was having recurrent runs of non-sustained ventricular tachycardia. Unfortunately, the patient was lost to follow-up. He's alive, I know he has not, but he chose not to do any intervention, and he remains at that. When I last saw him about 3 months back, his ventricular function still remains low, and he still continues to have multiple runs of non-sustained ventricular tachycardia. This is a patient which I said I encountered 5 days back. He's COVID positive. The first problem is whether we should manage him conventionally with thrombolysis or whether we should do a more aggressive management with angiography. We admitted this patient. Unfortunately, his pain continued to increase. His pain kept on getting worse. ECG showed very large ST elevation in anterior leads, and we had no choice but to take him up for an angiography. Fortunately, I did not have to encounter the second situation because when I did his angiography, all the 3 blood vessels of his heart had extensive thrombosis. They had only clots. There was no fat deposition. There was no atherosclerosis. It was only a thrombotic kind of blockage. And all I needed to do was just do something which is called a thrombus extraction. We pass in a very thin catheter into the coronary arteries and suck out the thrombus and leave them on blood thinners. Day 5, I think he's discharged. He's planned for discharge today. His blood flow settled completely with just clot suction, and we did not need to put a stent, or we did not need to, do any balloon dilatation. Just a plain thrombus suction helped us in this particular case. But a very interesting problem: a young male with COVID positivity presents as thrombosis in all the 3 blood vessels of his heart. This last problem, which is pulmonary embolism, is essentially the same problem as the previous patient, except that the clotting is happening on the right side of the circulation and not on the left side, causing bilateral pulmonary embolism. Many patients in second wave were given long-term anticoagulants for 3 to 6 months to reduce this particular complication. Fortunately, so far we have not encountered this complication to that extent in the third wave, but it's too early to say. However, this remains a serious concern: bilateral or pulmonary embolism due to increased tendency for clot formation in COVID infection. So to sum up, what I have presented today is the various kinds of cardiac complications in COVID infection, we have encountered rhythm abnormalities in the form of both tachycardia and bradycardia. And in the third case, also abnormal rhythm such as ventricular tachycardia and ventricular ectopics. As I told you, we've also encountered direct myocardial involvement in the third case of the right ventricle as well as the left ventricle. So again, both the ventricles are involved. And I've also shown you some index cases to show increased clotting and increased thrombosis, right-sided as in the last case causing pulmonary embolism, and left-sided as in the second last case causing a acute myocardial infarction. Now coming to the question which was raised right in the beginning, what does vaccination cause to cardiac issues? Whether lots and lots of patients ask me, "Sir, hum vaccine lagwa lein, sir, hum vaccine lagwa lein." Well, to be honest with you, as I told you, many things are not very clear. We don't understand whether vaccine also predisposes to some kind of an inflammatory response and therefore some kind of cardiac complications. But I can tell you, people have looked at data with individual vaccines very closely. And though individual case reports are described, and unfortunately, we live in an era where individual problems and individual complications tend to get magnified because of WhatsApp and social media and things like that. But data hasn't shown any significant increase in cardiac side effects. Data hasn't shown that you should withhold vaccine because of cardiac side effects. Similarly, there was a lot of data on Covishield versus Covaxin and Moderna versus Pfizer on inter-vaccine cardiac side effect variation, whether one vaccine is better than other and therefore we should prescribe one vaccine. Of course, as we know in India, this choice doesn't rest with the patient or even with the treating doctor, but there is no specific data to suggest that one vaccine is worse than others. Just a clustering of few side effects. There was some study from Israel and then some study from America saying that this vaccine causes increased thrombosis and things like that. Eventually, large data hasn't shown any specific inter-vaccine variation. So if I was to sum up my recommendation for cardiac patient, and I would, also urge you to kind of transmit it to the community, please encourage all cardiac patients to get fully vaccinated. Because we certainly know that COVID causes higher complications in cardiac patients. Therefore, the fear of vaccination should not withhold patients from getting vaccinated. In fact, trust me, when all patients in my OPD who come to my OPD, I ask them, have they taken the vaccination? If they've not taken, I ask my departmental coordinator to take them downstairs to where our vaccination is held to get them vaccinated. I don't force them, but I encourage them to take vaccination, all cardiac patients. So vaccination should be encouraged. To conclude, therefore, we understand that COVID has shaken the entire world financially, medically, socially, whichever way we look at it. Cardiac complications, as I've highlighted through these 4 or 5 cases, are very, very variable. I must admit, we do not understand why so many cardiac complications happen in COVID, whether it's a direct effect of virus or indirect effect of the immune system. Since we do not understand the mechanism, so far management is essentially along the lines of the underlying condition. If there is heart failure, treat it. If there is thrombosis, give them anticoagulation. If there is a electrical problem, treat it. Now, whether they are reversible, they are not reversible, what is their long-term outcome, we are certainly not very clear. As I mentioned, the rhythm abnormalities, the electrical abnormalities settle over 5 to 6 months, but we are not sure what's really going to happen on the long term. Now, this is a crucial question from my perspective, from a cardiologist perspective. Should we intervene on these patients? We know that when you do interventions in a inflammatory kind of a situation, complication rates are very high. We are not sure whether interventions are as effective as they are in a non-inflamed setting. Suppose a non-COVID patient, we know angioplasty has a complication rate of 1 in 1,000. Now, is it the same for an intervention in an inflammatory setting? We don't know, but I certainly know that it is lower than normal. Fortunately, so far, I must emphasize the word so far, in the third wave, we've not seen very serious cardiac issues. Maybe it's too early. Maybe the virus is not that serious. Whatever, I'm not sure. But we have not seen so many cardiac issues so far. But as I told you, it's too early to be careless about the third wave. Thank you very much for your patient hearing, and I will be delighted to entertain some discussion and some questions on this topic.
Thank you so much, Dr. Hemant Madan, sir, for giving us your time today. And now I request Dr. Muktinder Singh, Chairman, Scientific Committee and Academics, IHF, to give his comments as well. And we will take the questions then. Dr. Muktinder, sir.
Good morning. I first of all, on behalf of IHF, thank the learned and our experienced faculty today. Respected Dr. Saab has taken out this precious time to discuss this topic with we, the homeopathic fraternity. So, Doctor, I would like to draw your attention towards our science of therapeutics. The homeopathy was invented by allopath, Dr. Samuel Hahnemann in Germany. And when he saw that the disease is being managed in terms of the symptoms produced and the outcome, keeping the patient aside, as you said, that individualization, homeopathy bases on individualization. I'm very delighted to see that the cases you have presented today are all different. So we in homeopathy believe that every patient is affected differently by the same stimulus. So this law of individualization helps us to differentiate the different patient and manage accordingly. And I would again like to draw your attention that as you told that in allopathy there is no specific medicine for bradycardia, but in homeopathy we have many different prescriptions where we can really and we clinically see, although what I'm saying is not backed up by any clinical data, because we are most of the time only OPD practitioners working at our different locations without much infrastructure and without much exposure to scientific procedures. But I'm sure if given an exposure and given a chance to prove what I'm saying, we can definitely give a very encouraging output in terms of clinical trials, in terms of the presentation to the patient, and this integrative approach can really help us. So to mention, I in my practice has in my practice has seen that this post-COVID weakness with backed up by these changes in the ECG was very easily settled up with the right prescription. One patient I remember I prescribed Alumina 1M, who was so weak that he could not even speak. He was having bradycardia, weakness, and supported evident cardiac complication. And my dose of alumina selected on the basis of the symptomatic or the homeopathic way of prescribing helped a lot to the patient. In the same way, in another case, as you use digitalis, we also have digitalis 30 in our practice, and it prescribed on homeopathic principle. It helped our patients a lot. Our one of medicine Carboveg has lot of effect in cases of breathlessness and low oxygen levels. So that way, this is a very random thoughts what I'm presenting you, but definitely I appreciate the initiative of Dr. Amita, who have approached you and bridged between you and us, and we are really very lucky to hear our scientific case presentations along with management. And I am really impressed by the very simple way of presenting the cases. So I again congratulate the International Homeopathy Foundation, and I think we have some questions, but before that I would like your comments, doctor, so that what I have said and any experiences of yourself with homeopathy.
Thank you very much, sir. I'm glad that you use the word bridging in your comments. Of course, we need to bridge. Of course, we need to bridge. And as I told you right in the beginning of my talk, as you go ahead in life, you realize that there are many things that you don't understand and that you don't know. So I'm not an expert. All of us are experts in a relative field. I am not an expert in homeopathy as such, and I have not prescribed homeopathic drugs, but I'm sure I would be really keen to understand how these drugs act, and if they are useful, absolutely we must use them. If they are, kind of, if I can incorporate somebody, some learned homeopathy doctor into my practice, who can explain these things to me, who can, kind of help me in prescribing, or who can prescribe himself, I will be very happy to do that. So my comments are very similar to yours, that whenever you are encountered with a new disease, this is, after all, this is a disease which we've started, it's only 2.5 years old. If you read the history of medicine, cancers, it took nearly 50 years or 60 years before we even started understanding cancers. If we are to talk of one specific cancer, which is lung cancer, it took 30 years before people understood that smoking causes lung cancer. People would blame everything, but they would not blame smoking. So, in that sense, I'm with you on this, that we should, hit it with as much of knowledge across spectrums as possible, whether it's allopathy, whether it's homeopathy, whether it's Ayurvedic, whether it's some other kind of, treatment. So I'm with you on this. And I'm also with you, uh, which I urge everybody, all healthcare professionals, all scientists in general, that you should be humble about your knowledge, and more humble about the lack of knowledge which you have. That is very important, that if there is something that we don't understand, frankly admit that we don't understand. Because there is no point of uh, trying to boast about something which you don't have, which we don't know. So with that, I think we can go on to the question. It's a early morning, people must be heading to work, or must be wanting to head to work, so we can address some of the questions which have come in the chat box.
Yes, Dr. Amita, can you please read the questions,
Yes,
sir?
yes, sir. Yes, sir. The question is from Alam Virji. Alam Virji, I'm reading out your question. If you have anything to ask, sir, so I will unmute you. He's asking, sir, I had COVID in May, followed by long continued fever, and I'm having some problems which seems to be of some cardiac origin. Want to discuss it with you. Please give few minutes in the end if you can. So, Alam Virji, you can unmute yourself.
Dr. Amita, should we not, you can share my number with, because I don't know whether it's a good idea to share an individual kind of problem on a general forum, he may be hesitant or, you know, so you can share my number with Dr. Alamveer,
Okay, sir.
and he can contact me on a one-to-one basis. Is that okay, Dr. Alamveer?
Dr. Alamveer, you can unmute yourself. Dr.
Hello, good
Alamveer?
morning, ji. I am Dr. Sonika. It's okay. I can talk to sir individually.
Okay, okay, fine. I'll share his number with you then.
Yeah.
Thank you, ji.
Okay, thank you. So we will move on to the next question, sir. Let me just check the next question.
Next question is when to start and how long should we give blood thinner
Yes, sir.
in post-COVID as well as post-vaccinated?
It is by Dr. Sanjeev Agarwal.
Yeah. See, post-vaccination, we are generally not giving blood thinners unless they are already on blood thinners for some other reason. You know, like if there's a cardiac patient who's on aspirin or on clopidogrel, he's already on a blood thinner. We don't stop his blood thinners. But if a patient is not on a blood thinner, just as a precautionary uh, prevention to vaccination, we are not routinely prescribing blood thinners. Coming to the next question, that how long should we give in COVID patients? Well, as I told you, it is nobody really understands this, but we normally give some kind of blood thinner for about a month or so. For about a month, because we know that the inflammatory process lasts about a month in most patients. So we give them for a month. And after that, we do a CRP and a D-dimer test to see whether there is CRP for ongoing inflammation and D-dimer test to see whether there is ongoing increased clotting problems. If these two are normal, we stop blood thinners.
Okay, I can't see any other question. I think there is
No,
one.
there is one more
Yes, yes,
from
yes, sir.
Dr. Neetu Arora.
Yes, sir.
Tests like D-dimer, C-reactive, and interleukin-6. How much are they helpful in understanding the condition of heart during COVID and post-COVID state? Dr. Neetu, it's a very interesting question. Actually, see, these are tests which indicate we are trying to assess two different complications of COVID. By doing C-reactive protein and interleukin-6, we are trying to assess the inflammatory process of COVID. By D-dimer, we are trying to understand the clotting mechanism of COVID. They have no direct cardiac correlation. They only tell us whether inflammation is going on, whether clotting is going on. Of course, we, as I mentioned during my slide, both inflammation and clotting can lead to cardiac complications, but these tests are not cardiac specific. They are general tests to tell us about the activity of COVID. So I hope that answers the question, that they are not cardiac specific tests.
Okay, sir. I think you have already answered this by Dr. Shelja Sharma, EcoSprint 75 वाला जो है,
हाँ जी.
that you have
एक
already addressed.
एक और है डॉक्टर अन्वेश कोठारी.
हाँ जी sir.
Lady who has got right ventricle, right atrium and right ventricle dysfunction,
Shortness of breath and loss
shortness of breath,
nearly 15
and
to
they've
20
diagnosed
kgs of
it
weight
as
loss. Yeah, sir.
correct weight loss. And Dr. Anvesh, actually this is a slightly more, it may be COVID related, it may be congenital. I would suggest that Dr. Amita se aap number le lijiye and just share all her reports with me on WhatsApp or call me up, and we can thereafter take it forward from there, because it is very difficult to know from these reports whether she had underlying heart disease or whether it's a new phenomenon.
Yeah, Dr. Madan, I would again like to ask a general question about the general indications that we are an OPD practitioners, where to think of that this patient might be having some cardiac complications. So how to start thinking to refer or to go for further investigation? My question number one is, what are the basic clinical indications from which we can suspect that we can think we have to think about some cardiac complication? What are the basic tests we can get so that and what are the red flags from where we should definitely stop handling that patient?
Extremely interesting question, sir. Extremely interesting question. In fact, I designed my talk in a case-oriented manner just for this. Some symptoms patient will report on his own. Like he may come with fatigue. Some patients will come saying that हमारे palpitation नहीं होते, रात में सोते हैं तो छाती धड़कती है. These are clearly electrical abnormalities. As a basic test, anybody who complains of these things, the first thing we must do is we must do an ECG to diagnose whether this is abnormal electrical activity or this is normal but fast or slow electrical activity. ECG will help us in differentiating this. If you have access to the next level of test, the next level of test is obviously an echocardiography. If access to echocardiography is quickly available, we should do an echo to see the pumping action of the heart. Now coming to the second question, what are the other symptoms? Symptoms are exactly like that of non-COVID conditions. Heart failure will presents exactly in the same way. It presents with swelling over the feet, breathlessness, weight loss, maybe syncope or fainting attacks if there is intermittent electrical problem going on. So it presents in exactly the same way as a non-COVID patient. The only thing is that a history of taking COVID infection is very important, because many of these patients who had COVID and recovered, say 3 months back or 2 months back, they present 2-3 months later with these complications. Now coming to the third question of what are the red flags in our clinical practice. Any patient who has fainted even once, the red flag must immediately go up. History of COVID 2 months back, fainting even one episode, please do not ignore it. Similarly, breathlessness, which becomes more on lying down. Suppose a patient comes and says that he's breathless when he lies down. Pay attention to that, because it's very important. This is most likely a cardiac cause of breathlessness, and we should not ignore it. Thirdly, any patient who comes to us to say that he has swelling over the feet, don't ignore it. If the swelling is on one leg as compared to the other leg, it is likely to be due to thrombosis. If swelling is on both legs, it is likely to be due to heart failure. I think all these patients need to be hospitalized. All these patients need to be evaluated more carefully. Baki, some emergencies will keep coming. There are no red flags. God as yet hasn't given any doctor the power to eliminate disease. We can only reduce it. We can only cure it. So some emergencies will keep coming. Like I told you, that young boy planned for discharge suddenly died. A young man comes with a heart attack. There are no red flags. He comes with a heart attack. He comes with a heart attack. But at least these three symptoms: history of fainting, history suggestive of heart failure, and history of syncope. Never ignore.
Thank you, sir. Thank you.
Thank you very much.
You are very elaborative and very clear, being such a super specialist, and you are communicating with us who are almost like a layman to the cardiologist.
No, not at all, sir. Not at all.
So
I told you
appreciate
right
that.
in the beginning, we are all specialists in different fields of life.
Yeah. So
Dr.
I would like
Sunita?
definitely Dr. Amita to arrange few more talks that cardiac complications and cardiac differentiation with the most common gastric disorders. And one thing which I have encountered in my practice is that during menopause, it's that hormonal surge many a times give
Sure.
that kind of electric fluctuations, and that time it is really hard. We sometimes many a time refer the patient to the cardiologist, but that similarity between cardiac condition and menopausal syndrome, I would definitely like you to throw some light next talk.
Sure.
Definitely.
Perfect, sir.
Thank you.
Perfect, sir. Dr. Sumita, you have a query?
Yeah, I just wanted to ask if the patient is having re-COVID, Like now we are seeing that once the COVID was there in the second wave, even in the third wave, do we need to give blood thinners to the patient
Yes, yes, all over again, all over again.
all over again?
Yes,
Okay.
yes, you treat them like a new. In fact, there is a doctor in Apollo Hospital who's had COVID for the fourth time.
Mhm.
Four documented episodes of COVID infection. So,
So
and
every time.
he's fully vaccinated with the booster.
Mhm.
So, as I told you, individual variations will continue to happen. So we have to go by general, and that is where I hate WhatsApp knowledge and WhatsApp kind of dissemination of information, because it encourages individual uh, complications and individual failures while forgetting to talk about the general good that is happening. So as
Mhm.
a scientific community, I think it is very important for us to re-emphasize to each and every patient that don't forget, just because one person buys a car and meets with an accident in the first drive, it doesn't mean that the car is bad. It's, sometimes it's luck, or it's whatever you may call it.
Right. Yeah, because I am in US and I am doing little social service in a hospital. But
Yeah,
here
yeah.
the doctors, they are very much different and they don't communicate with the patient. And I'm really seeing that we Indian doctors are really more learned and more communicable to the patients than here. But still, I wanted to just check with the Indian community, which I am dealing with here. So I just had that question in
Yeah,
mind.
yeah.
Right.
Dr. Sumita, if I can just share my views, since you said you are in US.
Mm-hmm.
Uh, when we were students, we used to say that medicine is both an art and a science.
Right.
Now, what the Americans, by evidence-based medicines, by data analysis and all that, what they
Mm-hmm.
did is that they removed the art component from medicine and made it a pure science.
Yes.
Now, some of us old timers still continue to practice medicine as both an art and a science. So while data is important, it does not tell us about individual patients.
Right.
So
Definitely.
somewhere in your own practice, you develop a philosophy of
Mm-hmm.
practice.
Mm-hmm.
Even though you have data, you realize that perhaps this medicine or this drug may not suit an individual patient. So that is where the philosophy of medicine comes, which I think each doctor will make his own philosophy or will drive his own philosophy.
Right. Right, sir.
Yeah, thank you very much.
Thank you very much. Thank you, sir. Thank you.
Sir, we have one more question left. It is by Dr. Sucharitra. How to differentiate between pulmonary and cardiac cough in cardiac patient as post-COVID cough?
Again, a very interesting question. If you noticed any cough which is basically an equivalent of cardiac dyspnea, any cough which increases on lying down is more likely to be a cardiac cough. Any cough which is associated with other features of heart failure. What are the other features of heart failure? Swelling over the feet, increasing on exertion, features of the swelling over the leg associated with syncope. That means the patient faints intermittently. All these features suggest a cardiac cause. If there is a seasonal variation, suppose the patient very clearly says कि डॉक्टर साहब सर्दी होती है या मौसम बदलता है तो मेरी खांसी बढ़ जाती है, that is likely to be a respiratory cause. Similarly, any patient who has a strong history of smoking, again, they can have cardiac issues. They can have cardiac issues also, but more likely to be respiratory issues.
Okay. Thank you so much, sir. Any more questions, please?
Yeah, thank you all. We really, as International Homeopathic Foundation today, as Dr. Neelam from US joined and Dr. Javed from Ontario Homeopathic Medical Association is with us. So we have an international audience today. So I thank you also. I hand over Dr. Amita for the final closure of the event.
Thank you so much, sir. First of all, Dr. Madan, sir, I really thank you that आपने हम सबके लिए टाइम निकाला. जो इन्फॉर्मेशन आपने हम सबसे शेयर की, that is really valuable. I have one more thing to add to it is that हम डॉक्टर्स जो होते हैं, हम लोग कई बार अपनी हेल्थ को ही इग्नोर कर देते हैं. एंड बहुत सारे जो हेल्थ वर्कर्स हैं, हमने देखा है कि कितना उन्होंने कोविड टाइम पे सफर किया है, and they have lost the battle also. So considering that, मैं सबसे रिक्वेस्ट करना चाहूंगी कि आप लोग अपनी सेहत का भी जरूर ध्यान दें, बिकॉज हम लोगों को बहुत लोगों को ट्रीट करना है एंड हम लोगों पे बहुत बड़ी जिम्मेवारी होती है. So thank you so much, Hemant Madan sir, and I'm also thankful to Mr. Chetan Nagpal from Narayana Hospital, that who was a main point of source for me, where we can actually invite Dr. Hemant Madan sir for today. So thank you so much, Mr. Chetan, Narayana Super Speciality Hospital, to all the doctors who have joined us today, the students, and most importantly, team IHF, जिनके सपोर्ट के बिना, जिनके पूरी एक टीम ने जितनी मेहनत करी है इस इवेंट के लिए. So thank you so much, team IHF. And Dr. Hemant Madan sir, I would request कि हम लोग आपको इसी तरीके से bother करते रहेंगे in future.
Sure.
And जैसे
It will be a pleasure.
डॉक्टर मुक्तिंदर सर ने जैसे गाइड किया हमें, so we will have more topics with you, and if we can have more speakers on board. Thank you so much, Dr.
Thank you.
Hemant Madan sir.
Thank you very much.
Thank you so much for your time. So everyone, thank you so much. We will meet you again on 25th of Feb, and same time, 8 a.m. to 9 a.m. with another session. Thank you so much. Thank you so much
Thank you.
for attending. Allow me to end this meeting, sir.
Yes, sure. Please. Bye-bye.
Bye. Thank you so
Good
much.
day to all.
Thank you.
It's a
Good day to
really
all.
very good morning to all.
Thank you so much, sir. Thank you.